Hello students. So in this series of chapter, we are going to learn about the valvular disease. And our first topic is aortic stenosis. So if you have watched my previous videos, I think you know about what is meant by stenosis. So it is difficulty in opening. In this case, it's a aortic valve. Okay, what is the normal aortic valve? It is a 3 leaflets. That is 3 cups. If there is 2 cups, then it is bicuspid. If it's 1 cup, then it's unicuspid. So these are the abnormal cuspid wall, and normally it's a 3 cups. Now as the number of cups decreases, the stenosis increases. Okay, first of all we will start with the pathophysiology. Pathophysiology. So if you understand the pathophysiology of aortic stenosis, you can easily remember the symptoms of aortic stenosis and what are the clinical features we will get in it. Suppose aortic valve stenosis. What will happen first? It is the narrowing of valve. It can be due to bicuspid valve or degenerative or calcification or rheumatic heart disease. So these are the basic causes that will cause the narrowing of valve. Now what will happen? There will be obstruction to LV outflow. Suppose this is your heart, this is your left ventricle, and this is aorta. So this is your left ventricle and this is your aorta. Suppose if the space between this outflow is stenosis, then we can call it as a obstruction. So this is obstruction to LV. This is obstruction to LV. Okay. So what will happen due to this? Due to this, there will be increased left ventricular pressure. This is the stenos, then the pressure here will be increased, right? So what will happen due to pressure? There will be increase in muscle mass, that is hypertrophy. So it leads to hypertrophy. Next, from hypertrophy, there is a pressure overload. And what type of hypertrophy we get in this? It's concentric. Okay. Now, there is a pressure overload, there is a hypertrophy. So what next step will happen? We will get decrease LV compliance. What do you mean by compliance? Compliance means the change in volume. Since it's a hypertrophy, so there will be lesser amount of blood received by left ventricle. So there is increase in left ventricular end diastolic pressure. This will again increase left atrium pressure. This will increase pulmonary congestion. which will leads to dyspnea. So this is LV decrease in LV compliance, due to which there will be increased left ventricular and diastolic pressure. So the pressure of a left atrium will increase as well, since the pulmonary vasculature drain to left atrium. So the pulmonary congestion will be there due to the back pressure. So we get dyspnea. Now, due to this hypertrophy, what will happen? Due to this hypertrophy, there will be increase O2 demand, right? If there is a O2 demand increase, then there is a decrease in coronary perfusion, which will cause ischemia. See, concentric left ventricular hypertrophy will be there. Due to hypertrophy, the oxygen demand will increase, but we are providing the same blood flow to the muscle. So there is a decrease in coronary perfusion, and so as the ischemia occurs. So what we will get? There will be angina, that is chest pain. Now due to hypertrophy, there is a pressure overload and LV compliance decreases. What do you mean LV compliance decrease? It is like decrease in cardiac output, since there is a hypertrophy and there is a lesser amount of blood that can occupied by left ventricle. So there is a decrease in cardiac output. What happens if there is a decrease in cardiac output? There is a hypoperfusion to brain. And what happens when the brain is hypoperfused? There is a history of syncope. So these are the three main symptoms that we get in aortic stenosis. Okay. So this is the pathophysiology of aortic stenosis. Now what are the causes of aortic stenosis? So first one is the degenerative causes. This is the most common cause of aortic stenosis. It is due to calcification, atherosclerosis. Second is congenital. If there is a congenital bicuspid wall, associated with Notch 1 gene, which is autosomal dominant disease. Next is rheumatic heart disease. It is mostly associated with mitral valve pathology. Next, there is a subvalvular pathology, that is below valve. There is a subaortic stenosis, that is the fibrous membrane. Or muscular membrane will narrow LV outflow. So there is a fibrous membrane or muscular membrane that lies near the LV outflow, that is near the aortic valve. So it will decrease the diameter of valve. Also it occurs in HOCM. In HOCM, there is a hypertrophy of septum, hypertrophy of left ventricle, and due to this the space between aortic valve is decreased due to this hypertrophy. So HOCM is subvalvular. Then there is a supravalvular, that is above valve, which comprises of Williams syndrome. There are few rare causes, that is radiation induced CKD and inflammatory condition. Here there is a accelerated calcification. So these are the rare causes. Now, what are the clinical features we can appreciate in aortic stenosis? Male to female ratio is about 2 to 4 as to 1. Then we have discussed in pathophysiology, that is there is a angina, syncope and dyspnea. This is the triad of aortic stenosis. Then also we can get hepatomegaly. Now you could ask, why hepatomegaly? So there is a long-standing pulmonary edema which leads into pulmonary artery hypertension, which leads to hepatomegaly. So these are the basic clinical features that we can get in aortic stenosis. What are the findings in clinical examination that we can get in aortic stenosis? On examination, what are the findings that we get in aortic stenosis? So let's talk about the murmur. So first we get ejection, systolic murmur. Which type of murmur? Crescendo, decrescendo murmur. Can you apply cheat code on this? Yes, definitely you can apply. So we say aortic stenosis. Stenosis means difficulty in opening. When it opens in systole. So this is systolic murmur. Now why it is a crescendo and decrescendo? Crescendo means there is an initial increase. Why there is initial increase? Because there is a difficulty in opening aortic valve, and as soon as aortic valve, there is a sudden gush of blood that flows from left ventricle to aorta. So as soon as the flow maintains, the murmur decreases. So that's why it is a crescendo and decrescendo. What about pulse pressure? Pulse pressure is low. We get anacrotic pulse here. I will tell you what are the different types of pulse in next upcoming sessions. What happened to apex beat? So it is a heaving in nature. Why heaving nature? Because there is a left ventricular hypertrophy. It is always displaced to left side. Okay. What about the radiation of murmur? We can appreciate it in carotid artery, and it is known as carotid thrill. So the radiation of this murmur we can appreciate in carotid artery, and there we called it as a carotid thrill. Then what about the S2? So S2, as I said, A2 happen early, then P2, but since there is a stenosis, difficulty in opening, so more time for A2, thus this distance will decrease, so it occurs in single. So single S2, or there can be reverse splitting, that P2 A2 occurs after P2. What about S4? S4 will be positive because there is a left ventricular hypertrophy, and there will be gushing of blood that hits left ventricle which is hypertrophied. So there is some Gallaverdine phenomena. So what is Gallaverdine phenomena? So in aortic regurgitation, murmur radiate to axilla, and for same in aortic stenosis, there is a murmur that radiate to axilla. So these both can be confused. So murmur that occurs in AS is called as Gallaverdine phenomenon, which can be confused with aortic regurgitations. Now what type of workup we will do? So you will do first ECG. What are the findings of ECG in left hypertrophy? Can you remember? So there is a S wave in V1, and there is R wave in V5 and V6. In V1 it's a S wave, and in V5 or V6 it's a R wave. So that is ECG. What about chest X-ray? There is increased cardio thoracic ratio. What about echo? The size of valve. According to size of valve, aortic valve, it is divided into mild, moderate, and severe AS. If it is 1.5 to 2 centimeter square, if it is less than 1 to 1.5, if it is less than 1 centimeter, it is severe. So normally it is 3 to 4 centimeter square. Now what are the treatment option? So first of all, we have to control hypertension. Why? Because it will, if there is a hypertension, that means the pressure in aortic valve is increased, right? Pressure in aortic aorta is increased, so there is more pressure to work left ventricle. I mean, left ventricle has to put more efforts to push blood from its cavity to aorta. So the hypertension, we must control the hypertension through AC inhibitors or through beta blockers. Then there is one thing that I missed to tell you, that in patient with the aortic stenosis, the treadmill test and the stress echo is contraindicated. TMT and stress test is contraindicated. So please remember that don't do TMT in aortic stenosis. Other treatment options is surgical, and it is based on the clinical feature and the severity. So there are the severity stages of aortic stenosis. Stage A, B. Risk factor present, mild or no narrowing. In B, stage B, it is mild to moderate aortic stenosis with no symptoms. In C, severe aortic stenosis with no symptoms. In D, severe aortic stenosis and patient is symptomatic. So for D, we go for TAVR, that is transcatheter aortic valve replacement. In stage C, we go for TAVR in few cases, like if the patient is having TVD, if the patient is having EF less than 50%, if patient is having transvalvular gradient more than 60 mm of Hg. So these are the treatment options that we can do. For here, there is a treatment of controlling hypertension through AC and beta blocker. Now let's start with the aortic regurgitation. So aortic regurgitation is a somewhat difficult topic, and it has too many signs that one has to remember it all, and it is most frequently asked questions in NEETPG as well. So what is aortic regurgitation? So as we know, regurgitation means there is failure to close which aortic valve. Which valve? Aortic valve. So what happens? Suppose this is your left ventricle, and this is your aorta, and this is the valve. Since this valve is not able to open properly, what will happen? After the systole, this AV valve supposed to close, but since it is unable, then there will be leakage. So let's apply our cheat code. What do you mean by regurgitation? Means failure to close. Where does it closes? It closes at early diastole. So there is a diastolic, early diastolic murmur. So this is the basic concept behind aortic regurgitation. Now let's study the pathophysiology. Pathophysiology is very important because once you know the pathophysiology, the clinical features and the whole concept behind that particular topic is covered. So pathophysiology of AR. So whenever there is a aortic valve incompetence due to anything, either it from RSD or from infective endocarditis or from aortic root dilatation. So there is failure to close AV valve in diastole. This, what will happen due to this? This will, there will be regurgitation of blood from aorta to LV, right? So there will be increase left ventricular blood, right? Increase left ventricular blood volume. Okay. So there is increase left ventricular end diastolic volume. This is the keyword. You have to remember that there is an increase in left ventricular end diastolic valve. Suppose X amount of blood has to be there in LV, but due to regurgitation, there is X plus regurgitated blood. So at the end, there is increased left ventricular end diastolic pressure. That is, at the end of diastole, there is a more blood than expected. So to pump this blood, there is increase left ventricular hypertrophy. Since there is a more blood than expected, the left ventricle has to put more efforts to pump that blood into aorta. So there is a left ventricular hypertrophy which is eccentric. So what do you mean by eccentric? Eccentric means there is increase in cavity size, that is dilated, plus there is hypertrophy. So this will create large plus floppy LV. Previously, aortic stenosis, we studied concentric. So what do you mean by concentric? There is a decrease in cavity plus hypertrophy, and heart left ventricle is stiff and large, but the cavity is decreased. Okay. So here in aortic regurgitation, we will get the eccentric hypertrophy. Now there is a regurgitation of blood, that is increased left ventricular blood volume. So what will happen here? There will be increased stroke volume, right? Because this, there is a blood X plus regurgitated blood. So the systolic blood pressure will increase, SBP will increase. So there will be bounding pulse. Similarly, whenever there is a diastole, in diastole, AV valve supposed to close, but it doesn't in case of AR. So in diastole, blood in aorta is decreases. That means there is a decrease in pressure at aorta. So decrease diastolic blood pressure. Now what happens in diastole is, I hope you remember the concept, this concept in physiology. The blood supply to left ventricle is in diastole. So since there is a decrease in diastolic blood pressure, there is decreased coronary blood flow. Due to decreased coronary blood flow, there will be angina, right? So we have said there is increased SBP and decreased diastolic blood pressure. That means SBP minus DPB is higher. So pulse pressure increased, right? This is the sign we will discuss later. Now there is a chronic LV overload. What will happen in chronic LV overload? There will be progressive LV dilatation. So it will increase wall stress, which will land up in LV systolic dysfunction, and eventually it will cause heart failure. So this is about the chronic LV overload. Now what happens in acute AR? Acute AR. In acute AR, there is a sudden regurgitation into LV, and there is no time for LV adaptation. So there is a rapid increase in left ventricular and diastolic pressure, which will again increase left atrial pressure. So there will be pulmonary congestion, which leads to pulmonary edema and hypotension and cardiogenic shock. Okay, so this is the pathophysiology of aortic regurgitation. The most important thing is there is an increase left ventricular and diastolic pressure. So this will create the hypertrophy, which is eccentric in nature. Also there will increase in systolic blood pressure, and there is a decrease in diastolic blood pressure due to blood regurgitating from aorta to left ventricle in diastole. So there is decreased diastolic blood pressure, which turn into decreased coronary angio flow and angina. So the pathophysiology of acute AR is different and chronic AR is different. So this is the pathophysiology. One thing I want to make you clear, that in night what happens, there is a bradycardia. So what happens in the bradycardia, there is an increase in diastolic time. Since there is increase in diastolic time, there will be more blood leakage, right? So there will be more decrease in coronary blood flow, right? So the angina increases. This is called nocturnal angina. which is a characteristic feature of AR. Then what are the causes of AR? So the first cause is cautery, cuspid, valve, infective endocarditis, rheumatic heart disease, syphilis. Syphilis is one of the cause that is frequently asked in NEETPG. Then there is a aortic root dilatation in Takayasu aortitis. Then aortic dissection, Marfan syndrome. AR is also associated with AR is also associated with ankylosing spondylitis. That is associated with HLA B27, right? Then myxomatous degenerative valve, myxomatous. So these are the causes of aortic regurgitation, and most of the question will be asked with the association of this one of the cause. They will give you an example of RSD, they will give you the clinical signs, they will give you the findings, and they will ask you what is the treatment or option. So they will ask you indirectly by asking the diagnosis and the treatment as well. So these are the causes of aortic regurgitation. Now what are the clinical features? So clinical features, first is the symptoms. So as I told you earlier, there is a angina, also nocturnal angina, there is a dyspnea, there might be the exertional dyspnea, orthopnea, head pounding sensation. So these are the typical symptoms that will be presented by the patient. He will say that patient, sir, I'm sleeping at the night and suddenly I get a chest pain which is unbearable, or he may be complain of breathing difficulty after the exertion, and he will tell that my head is like, I feel like a pounding sensations in my head. So you these are the symptoms of aortic regurgitation. So with these clinical features, what findings that we can get? So there are many signs. So there is a long list of signs that we have to remember, and it is very important for your clinical examination and your future perspective. Let's start one by one. First one is Corrigan sign. So this is prominent carotid and supraclavicular pulsation. So you can appreciate there is a carotid artery near your neck and supraclavicular area where you can see there is a prominent pulsation. Then DMUSET sign. So it is a head nodding with heartbeat. So there is a patient sitting, and you will find that his head is nodding as per beat. So you can suspect demucet sign. Though these signs are very difficult to find out, but if you find one, then it is a demucet sign. The next is Landolfi. So Landolfi sign is change in pupillary size with heartbeat. So size will change as per the heartbeat. Then the Mueller sign, it is uvula pulsation. We ask patient to open his mouth and you will see the pulsation as uvula. Then Becker's sign, it is a retinal artery pulsation. Then Rosenbach sign, it is a liver pulsation. Then Gerhardt sign, it's a splenic pulsation. Then there is a Quincke sign, it is digital capillary pulsation. Then there is a lighthouse sign, blanching and flushing of forehead. Then there is a Hill sign, blood pressure in lower limb is more than upper limb by almost 20 mmHg. Then water Hamel pulse sign, high volume and collapsing pulse. Then Traube sign, so it is a pistol shot in femoral artery. Whenever you are going to palpate that femoral artery, it will feel like someone is shooting guns. Then there is Lincoln sign, it's a popliteal artery pulsation. And there is a Sherman sign, pulsation at dorsalis pedis. So these are the list of signs that you can remember for aortic regurgitation. Then there are some clinical signs that we must understand and we should remember it. So as we discussed earlier, there is a decrease in pulse pressure, upper limb BP and lower limb BP less than 20 mm of Hg normally. But in case of aortic regurgitation, this is more than 20. which is called as Hill sign. What about apex beat? It will be heaving type because the left ventricular volume is increased. Also, it is displaced due to hypertrophy and due to LV enlargement. In aortic stenosis, we have heard that murmur thrill will be there at apex, right? What about S2? It will be soft as it is difficult to close. We also discussed about the murmur. So what type of murmur we are going to get in this AR? It is early diastolic. So early diastolic, how it is like? It is a decrescendo. So how exactly it is a decrescendo? So at diastole, early diastole, AV valve supposed to close, but it doesn't. So there is a leakage or regurgitation to LV, right? So as soon as LV starts in diastole, there is leakage. So after some time, LV will be filled with blood from mitral valve plus leakage. So after a certain time, there will be enough blood. So as soon as the blood increases, there is a decrease in turbulence. So at empty space, if you put a blood or water, turbulence is higher. But if the any space is half filled, the turbulence will decrease. So same goes with this ER. So it is like this. There is a name called as Austin-Field murmur. So this is a mid diastolic murmur. So these are the clinical features and lab finding that we can get in aortic regurgitation. Now, what are the investigation to be done in AR? First, we will do ECG. What it will show? It will show left ventricular hypertrophy, S wave in V1 and R wave in V5, V6. Same as a same as in aortic stenosis. This is V1. This is V6, V5, V6, V5, V6. Chest X-ray. It will show cardiothoracic ratio more than 0.5. Echo will show regurgitation volume more than 60 per bit. So what is the treatment? So there is a different treatment in acute setting and in chronic setting. In acute setting, there is a pulmonary edema and we want fluid to be removed from body. So what do we use? Furosemide. So we use diuretics. We can also use NTG to decrease blood pressure. IABP, that is intra-aortic balloon pump, is contraindicated in aortic regurgitation. because it will worsen AR. What about the chronic AR? We treat the cause like infective endocarditis, like Takayasu, like aortic dissection. Also pharmacologically, we can use NTG and diuretics. So these are the main things that one has to remember in aortic regurgitation for the preparation of NEET, PG, FMGE and all exams. I hope you got a decent idea regarding the clinical feature and pathophysiology. I always say that the pathophysiology is very important and one must remember the pathophysiology, because as you know the pathophysiology, you can imagine the every question that what they want from you. So thanks for listening. We'll continue next chapters for valvular diseases. Thank you.